I'm Peter Block in Chicago at ACC 2016 for On the Scene. Standing next to me is Deepak Bach, my friend who we've done this 1,000 times together, and Deepak has just reported on a negative trial. I'm going to ask Deepak to tell me about the trial in about half a sentence, and then I'm going to ask the most important question, which really is something that you folks out there need to learn about negative trials. So Deepak, tell me about your trial very quickly.
Sure. It was a study of an intravenous antioxidant medicine to see if it would reduce contrast nephropathy and to see if it would reduce periprocedural myocardial infarction. So a 2-for-1. We were looking for two different things with one intravenous antioxidant.
And it didn't work.
It didn't reduce contrast nephropathy. It didn't reduce periprocedural myocardial infarction.
All right. Negative trial, everyone says, oh, for God's sakes, I'm going to turn off everything. I don't care about this anymore. Now, let's shift gears. What do you learn from this negative trial? Because that really is the base. You always learn something, don't you, Deepak?
Absolutely. So first of all, I would say that most well-done clinical trials are negative. That is, it's rare for drugs or devices to work. Most things, when they're studied rigorously, are negative studies. So that's the first point. But in terms of what we learned, yes, you always learn from doing clinical trials. Always learn from any sort of data, but in particular when there's randomization in clinical trials, there's a lot to learn. One thing we learned here that I think is quite important, it's a message we've heard before, is to not put too much faith in preclinical data. So there's a lot of preclinical data that supported this. It looked great in animals, but in humans it didn't pan out. And in fact, in this case, there actually was a previous human study, small, that showed a benefit for the highest dose in reducing periprocedural MI, and we were unable to confirm that finding.
And we see this time and time again, don't we?
Yes, we do. So it just shows you can't rely on surrogate biomarkers in humans. You can't rely on animal data. If you really want to know if something works, you've got to do a properly designed, rigorous trial. There's no way around that. The other thing we learned here that I also just want to mention beyond just clinical trial design related issues has to do with the topic of study, contrast nephropathy. There's a lot of it out there, and it's a problem. So, we saw in this trial that patients with contrast nephropathy, about 20 to 25% of these high-risk patients undergoing PCI had contrast nephropathy. There was a high rate of prolongation of hospitalization. There was a high rate of repeat hospitalization. So, as you know, as a busy and practicing interventionist, when that creatinine bumps, maybe you don't think it's a big deal, but you're kind of stuck with them until it goes back down.
It is a big deal.
Yeah.
Hospital-wise it is.
Absolutely, and then you keep them in the hospital, you hydrate them. Maybe if it's a big bump in creatinine, you call the nephrologist. They don't really do anything, but they tell you to keep watching the patient. So, it is a healthcare cost issue.
Okay, so there you go, folks. A negative trial, Deepak agrees, but a ton of information that comes out of this trial. And, don't throw away negative trials. They always have something to tell you.
Yeah, absolutely. You can always learn from them.
Thanks, Deepak.